All right, folks, we're back. Sorry about that. A little freeze up on the camera, but you did not lose us at home, so that just took a minute. Dr. William Whaley and Dr. Raymond Tidman. If you did not catch my little, he flew in, right, landed.
On his fanny.
Right?
Yeah, from a hang glider.
Yeah. I appreciate that he gave me the option of running out versus sliding, because I don't like broken ankles. But
So you like that old joke, I just flew in, and boy, are my arms tired.
Yeah.
Well, you missed. I didn't send you the initial setup, but backstory is 15 years ago I met this guy on going up a lift to the Klein Matterhorn, which is one of the higher mountains out there where I was, and he had this humongous backpack. So anyway, met him, talked to him, decided I was going to do the parasailing, and so we get up there on the day of the parasailing, and you're standing on snow. He's got everything spread out behind you. You're tandem, so you're all in the gear. He's in his gear. He latches to you. And here are his final instructions to me. You want to hear it?
Yeah, we want to hear it.
So, Dr. Tidman, I can see that you think a lot. I need you to not think. I need you to listen to my voice.
Wipe it, right?
Yes. Don't think. Listen to my voice. And when I tell you to do something, you do it. And I said, Phil, my brain is saying, don't move. So you better talk loud. And he said, well, run. Anyway, it is an incredible experience. I mean, you have to have the fortitude to do it. But do it. If you've got that fortitude to do it.
There's not many fatalities from that.
No.
No. Probably 8, 10%.
Do you have a survival chart?
Well, let's put it this way. The guys that do the flying wingsuit, all of them are dead. Okay. The parasailers, here's the beauty of it, is as soon as you get over the edge and the wind picks you up, you feel the strength of that air. And you go up. You don't go down, you go up. And it's like you're like soaring like a bird. It is a majestic, peaceful, serene feeling.
Now, if people want to see this, they need to watch any golf tournament at Pebble Beach on television, and you'll see these guys golfing, but you'll see all of these hang gliders coming down the road there. And I don't know what they're coming off of, and they're coming, they can turn, and they go back over they turn.
You've got the thermals, and you got the lift of the air, and so actually the air is pushing the glider. It's a parachute. It's pushing it up. You have to drive it down.
Well, we need to get you back to thinking.
Okay.
Let's do that. We got to switch that gear back.
All right, I'm going to switch.
We're glad to have you
I'm
back.
switching another gear.
Georgia Cancer Specialist, Northside Hospital Cancer Institute. Thank you very much.
This is great.
Glad to have you back.
This is great entertainment, but the people that are from Atlanta watching and think that it's really big deal on how they do. Mark Aram, and he says, we are doing this before a live audience. We are here at Circuit World before a live audience. Get a little clapping over there if you would. There you go. All right. So here's the deals. Now this first question here is a really good one, because I remember before the epidemic, we had a patient that we discussed who was in her late 80s who had a huge tumor in her lung that we had a picture of, actually, that was bigger than a baseball and was not in the least bit sick. And we went back and looked, and there was a picture that she'd had from somewhere else about 8 years before that thing was in there, and they had mentioned it, but nobody had done anything about it. It's a good thing, because she wasn't very sick. So listen to this question. My father's not sick. Now that's the great way to begin it. He's 65 years old, and he went to the ER for a broken rib. Okay, so now you got a not sick guy who's in a healthcare institution, showed multiple small spots, and a CT of the abdomen done the next day shows a large mass replacing his kidney and invading the blood vessels. Now at that point, the report's going to say renal cell cancer with lung metastases. So she doesn't put that in here. She says the oncologist. So we can see there's been a step since the ER visit. They've made a diagnosis of cancer, and the kidney is obviously the mass, and the thing, and the lung's the spot. She didn't put all that in there. The oncologist wants to biopsy the lung spots and says there are new therapies for kidney cancer that are not chemotherapy or radiation or surgery. Must be targeted therapy, huh, Ray? If so, why biopsy the lung? Now, we have lots of questions that are asking about, should I follow my doctor's advice about this treatment or that treatment? But this is a pretty good question. Why would you biopsy the lung if you know from looking at it that it's a kidney cancer and it's spread to the lung and you've got therapies for kidney cancer?
Well, you always need the histology. You always need the absolute diagnosis.
Well, one of the reasons might be the insurance company wouldn't pay for it if you didn't have a path report, but that's not where we're going to go with the answer. You're right. Okay. Put up that first one there. Now, this is just a title of an article that's talking about the treatment of advanced non-clear cell renal carcinoma. Pull that down. Now, what does that imply? If they're talking about non-clear cell renal carcinoma, that must imply that there is clear cell renal carcinoma. Now, let's go back to the lung. Remember, we've got non-small cell lung cancer and small cell lung cancer with two totally different biological behaviors and two totally different ways of treating it. So put up the next one. What's that?
Is that
algorithm?
Yeah,
all right.
Yeah.
The approach to the initial systemic therapy in patients with, this would be metastatic clear cell renal cell cancer. So this is all of this great progress that's been made in kidney cancer has been made in clear cell renal cancer, which fortunately is 75% or so of the renal cancers, okay? So we're not going to have to work you through this whole thing here, but here's the interesting point. And we're going to talk about risk factors in a minute, but talks about risk factors. And then it says, if these things are smaller than a certain size and less than 3, you can surgically remove them and surgically remove the kidney. Remember, just like we did with that, I think 2 weeks ago or last week, we had the rectal cancer in the liver. Remember, we took out the liver thing, we did the rectal. So pull that down. So the concept of a kidney cancer that has 1 or 2 metastatic lesions that can be removed, if it can be surgically removed, do it. But if it can't, then that's where we're going next. So put up that little survival curve. We won't spend much time looking at it. But this survival curve is the survival curve of lots of little spots versus few little spots, so to speak. So if you've got many metastatic lesions and cannot surgically approach them, pull that down. It's not as good a picture as it is with 1 or 2 that you could get out. So where this then becomes, the question is about treatments that are not surgical, radiation, or chemotherapy. So our next, throw it up there now. So while we're talking about what is the state of the art in systemic treatment for metastatic renal cell cancer. So that's where the question is now. Why biopsy it, right? All right, pull that one down. I'll be darned. What is this one here?
Algorithm.
Another algorithm. All right, BJ, we're doing good.
You could be a computer programmer.
I'm looking at these. So we have another algorithm. The question is, if so, why biopsy the
Yeah,
lung?
all right. So when you get to that point where you can't remove them, there's too many of them and everything else, it gives you, this is the same thing we did to that guy with the rectal cancer and the liver metastasis. That might have been last week. It wasn't. It was a week before that. Systemic therapy with possible cytoreduction if there's a major response. Okay, pull that down. So this concept, I mean, I think it's really important when you're talking about any malignancy, but this concept did not exist for renal cell cancer before 2 years ago.
Well, and what's the concept?
The concept is that by giving treatment when you have disease that cannot be surgically removed, you reduce the bulk of the disease that converts it into a surgical stage. Remember, I used that analogy about dropping the pebble in the pond and the ripples ripple out, and if a breast tumor is bigger than 2 centimeters, you give chemotherapy and suck it back up so they can then get it out.
Okay, but let me back up here because debulking the cancer with a chemotherapy is
Well,
not new.
No, this is targeted therapy. I said it was new for renal cell.
For renal
cancer.
cell.
Yeah.
So now there is a therapy, there is a chemotherapy that,
You keep saying chemo.
Well,
I know
not
it's,
chemo.
there is a
tr-
systemic therapy. Yeah, that
and
is a
that, but
targeted.
the systemic therapy is the new thing.
Yeah, it's an immunotherapy, targeted therapy, no chemo. We didn't have squat for renal cell cancer before Keytruda. Remember that? We used that drug all the time, and we didn't know Keytruda worked for renal cell because there's so many fewer, and they were first using Keytruda, on lung cancer, which it seemed to work on, and Keytruda or drugs like it are the key for here.
Is there a marker that tells you in advance that,
No.
that the immunotherapy is going to work?
Well, there is for lung cancer and other cancers, but not for renal cell cancer.
That is also very cutting edge, those markers.
Yes, yeah, that's exactly why we're doing the biopsy. All right, now,
Yeah.
so here are those risk factors that this guy obviously has none of. He's a healthy guy. The risk factors that would where you would say you're not even going to fool with this is the guy is not capable of self-care. Well, obviously he is. He's not. He's healthy. There's nothing wrong with him, so he's not badly anemic. You can pull that down. So he doesn't have any of these bad risk factors. So
His other kidneys functioning okay.
yeah,
and his blood pressures are not going
doing
crazy.
a great
and-
job.
yeah,
So
yeah.
when we'll throw this up, just show it to you. This is a series of survival curves, right? But what it does is it breaks you up into poor risk, intermediate risk, good risk. Well, this guy would fall in the good risk category. So if you take these survival curves, that whole survival curve is higher than that whole survival curve is higher than that whole survival curve. You can pull them down now. But those curves are just how strong is the patient, not how far is the disease. Does that make sense?
Yeah, how otherwise healthy
How
is the patient?
otherwise healthy. You remember I said that this guy's 65 or 68. At that age, George Burns was having sex with Las Vegas showgirls and did it till he was 99. So you have
At
to
least
treat.
he claims he did.
He did. Well, that's what they say. So you have to treat people to their biological age.
I know he smoked cigars till he was 100. What else he did, I'm
102.
really not aware
Oh,
of.
right, okay. Well, anyway, but the point is that you treat this guy according to his biological age. We have just determined he's not sick. None of those risk factors does he have. Therefore, biopsy the lesion, and you've got a 75-80% chance it's going to be clear cell. They'll be able to run the pattern of markers, as Ray says, and then you got this last algorithm that breaks you up into 3 different sections, and those 3 different sections just tell you which targeted therapy, you can pull that down now, which targeted therapy is best for his actual genetics on his clear cell lung cancer. So it'll tell you whether to get chocolate, vanilla, or strawberry, like you're getting ice cream or something, and whether you get that, you put that with cookies, cake, or some other thing. So you got 2 different categories, and it's going to tell you which immunotherapy to get, chocolate, vanilla, or strawberry, Keytruda, blah, 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 and what the second drug to take with it is, and then you're going to have a specific therapy for this guy, for his tumor, and you won't get that without the biopsy.
Let me interrupt for a second and reframe this. Using the word frame like we do in photography, when you you set something up and you look at it from this angle, well, you can reframe it, look at it from another angle, have the same information but at a different angle, and you get different information.
Yes.
Old school, Bill and I, when we were in training, you looked at the anatomy, you had a microscope, you got a piece of the tissue, you looked at it through different stainings, and you made a diagnosis based upon what you were seeing in the microscope. Okay?
Yeah.
That's what's going on here. Image, there's a big mass on the kidney, there's stuff in the lungs, get the easy stuff out of the lungs, look at it under the microscope, clear cell, not clear cell. Now we have algorithms that say, well, how might this patient respond? We don't as yet have a marker for the clear cell renal cancer that says it will respond to Keytruda or not, so you give it to them and see if they respond. The real technology change in the last 10 years, Bill,
Yeah.
is not only immunotherapy, these other lines of therapy using the body's own immune system to attack cancer, but finding the markers that tell you that the cancer will respond to therapy A versus B. And therefore, you can early on know which therapy to apply first.
Yeah, which is the best?
Which is the best.
Which has the statistical
likelihood.
chance?
Yeah.
One of the concepts that's easy is you got a woman with a urinary tract infection. Okay, it occurs 2 or 3 times. You got to go culture it to get a pattern of antibiotic sensitivity, because there's 97 drugs for a urinary tract infection in women, and when it's first time, you go to the penicillin, the standard drug, whatever that happens to be. But after they're treated and they got better and it comes back, you say, wait a minute, we're just selecting out here maybe an antibiotic-resistant urinary organism, and we'll culture it again. So that's a concept you're familiar with doing all the time, and so that's really just a marker that it's going to respond, just like cancer. There. So bring it down to something easy.
Yeah.
You got it?
Got it.
All
Sure
right.
do. Thank you, Georgia Cancer Specialist, affiliated with Northside Hospital Cancer Center, for these questions, for supporting us while we answer these questions. The second one here, this is like, I've been doing this too long. Like, I recognize.
I understand. And what it begins, you discussed this a few months ago.
Yes, and when they start talking about squamous cell and.
Yeah, but this is Merkel cell.
I got it. And Merkel, I got it both. All right.
All right. Now, this is an interesting thing, because there are only 2,000 cases of Merkel cell cancer diagnosed in the United States a year.
Interesting.
There are 380,000 cases of lung cancer. There are even more than that of prostate cancer. I mean, 2,000 cases, and it's been 6-8 weeks. We've had 2 separate people with Merkel cell cancer making questions to this program. I think that's amazing to me. All right, you discussed Merkel cell cancer a few months ago. Now, you remember that patient had a huge mass in the neck, had big metastatic disease, and we were treating them with, what was it? Immunotherapy. That patient got Keytruda and went into a complete remission. And the question was, should they continue the Keytruda? Remember? So this was a much different case than this one. All right, Merkel cell cancer a few months ago. My father is healthy. Here we go. Here's another healthy guy. He's 70 years old. The dermatologist biopsied a spot at the same place as an old squamous cell cancer. So here's an old guy like me, been out in the sun too much, had a squamous cell cancer. Somebody in his group, the family practitioner or the dermatologist or the daughter, is making sure what? That he goes back to be re-inspected. He goes back to the dermatologist. A lot of people don't go back. This guy has been going back, obviously. So this is a good thing. He's getting up to state care, because the dermatologist biopsied a spot at the same place as an old squamous cell cancer. That just tells you the guy's going back. It was Merkel cell cancer. The cancer and a few lymph nodes were removed by an ENT surgeon, and they got it all. What does that tell us? 2 things. One, the dermatologist had enough sense not to mess with it once he knew it was Merkel. 2, he sent him to a cancer-type head and neck surgeon, so that means this Merkel cell's someplace on the face, on the jaw. They didn't tell us that, but by the fact that it was an ENT surgeon and not a plastic surgeon who would be working down in here, then it's up here somewhere, and they got it all.
Yeah, they emphasized got it all. Got it all. All capital letters.
Got it all. Got it all. The oncologist did a PET scan, which was negative, but suggests radiation therapy because of high-risk features. What say you?
What say you?
All right. Now, that's the same thing. Remember the breast cancer, when we do the lumpectomy and the lymph node dissection, you don't get the same response as you would get with a mastectomy unless you add radiation therapy to make sure the rest of the breast is sterilized.
Let me ask you a question inside this question.
Yeah.
Because I'm listening, I'm reading this, and tell me if I'm correct in following the question. The person asking the question is saying the surgeon, and they told him to come out, and they said, we got it all.
Yes.
Okay. So in one way, are they saying if you come out and say we got it all, then what are high-risk features? Why the radiation if you got it all?
Great. That's a good question because the surgeon generally has got it all.
Right.
And
Is that what they're asking?
Yeah. Well,
But he can't be certain of the little microscopic.
Exactly.
All right. Remember now, we got it all because. Well, let's go back to the breast cancer because if it's over a certain size, you're going to get hormonal therapy or chemotherapy because those cells can be circulating in the bloodstream that have penetrated a blood vessel, even though the tumor is gone.
Right.
So you don't ever die of the tumor where it is. You die of the tumor because it spread someplace.
Right. Okay.
All right. Now let's go back. So the first thing we're going to do is we aren't going to go back and give you that encyclopedic. Remember what made a watch when you told me what time it was. But anyway, put that first one up. Putting this one up, they say, what are the first symptoms of Merkel cell carcinoma? And there aren't any symptoms. It means you got a spot on your body somewhere. But the reason I put this one up, because this is that glistening, pretty red thing that was the picture we showed a couple of weeks ago because they had discussed how that one appeared. You got that? All right, pull it down. Now, we know that this one occurred in the spot of a squamous cell. You know, that's a pretty picture there, all that pink and red and everything. Now, Ray and I have had these on our head. Why did we get them on our head? Because we ain't got much hair, and we've been out in the sunshine. You know, I had that big one removed last year here, and I had one removed here. So they go back in a spot where there was a squamous cell cancer, and they make a shave biopsy. They say, look, this might not be anything, but they didn't freeze it, did they? So, you know, a lot of times they freeze these sun damaged things. So the dermatologist was smart. If there was already a squamous cell there, I'm not going to freeze it off, even if it doesn't look malignant. All right, let's wipe up this. We're going quick here now. Key statistics for Merkel cell carcinoma. You got that one up? Got to pay attention. Now pull that one down. I told you there were only 2,000 of these a year. If you've got localized disease, just to this spot, then you got a 76% 5-year survival rate. You don't need to worry about the rest of this because this guy's is localized. But regional would be it's spread out to other lymph nodes or something like that. Distant metastases would mean it was in the lung. Now the guy, we can pull that down now. The guy we had last time had it locally and it had spread to lymph nodes and Keytruda made it go away, remember? And then the question was, how long would they continue the Keytruda? So we'll look at this very, very, very briefly, but all of these are different survival curves for people like this guy who had a positive sentinel had microscopic disease in a lymph node. So this just is how big is the disease in a lymph node. Now pull that one down. This next one, these two different survival curves represent the long-term survival depending on how big the tumor was. Now pull that one down. Now just hold that one down. So we have shown that it makes a difference how big the tumor was, how much of the lymph node was involved, and in breast cancer they say there is lymphovascular invasion, meaning it's invading a lymph channel or blood vessel, or there is no lymphatic or vascular invasion. And since the oncologist has said he has high-risk features, even though the daughter, I guess, doesn't know what they are, I guarantee you it's blood vessel invasion, a small lymph node in the area there that's involved, or the size of the tumor and depth of the tumor. So that's what a high-risk feature is. All right, put this next one up. Got it up? Okay, this is the equivalent of an algorithm in a chart form. So, if you have this, the way this is treated in his way is you got to get a big margin around the tumor, like a melanoma. You've got to do a sentinel lymph node biopsy, like a breast cancer or a melanoma. And then, what's it say next there? What's the third one on the list? Radiation therapy
Yes.
to the tumor bed and draining nodes.
Yes.
And then the next one says chemotherapy is of no benefit. So breast cancer, we would be giving them chemo. Chemo doesn't do a squat for Merkel, remember? So there's no benefit from giving them chemo. There's no benefit from giving them any other targeted therapy at this point. All the benefit is in sterilizing the region around it. Remember, this thing came in a spot previous cancer had been removed in. I don't have it turned off, do I? There. So these risk factors that this patient had, which are not listed, have to be microscopic invasion of a blood vessel or the positive lymph node, and then the treatment is, got it up there?
Radiation.
Easy though. See, that's the head and neck.
That's a target radiation.
Okay, pull that down. The only thing about that radiation is it's going to be 5 minutes a day, Monday through Friday for 4 weeks. And if you went back to that survival curve, that top curve where the long-term survival's there is the people that get adjuvant radiation therapy compared to those that don't. So, the question is, the doctor wants to do radiation therapy. That radiation therapy is a jelly roll except for driving there and driving back. There are 0 side effects, not zero, but essentially 0 side effects, so this is going to be superficial radiation. We know it's going to be to the head and neck because it was an ENT surgeon that did that, so it's not going to make any burn in the lung or like that radiation we had with the rectal cancer a couple of weeks ago where the guy had the bad cystitis. Remember the bleeding in his bladder and all? None of that stuff's going to occur. Anything that's going to occur up here is going to be a little sunburn to the skin or a little dry mouth underneath it that's going to get better. So, I say, let them radiate your dad. It's going to take that survival curve from here and give him a 75 or 80% chance he's going to live out there like George Burns and die of something else.
You good with that?
I'm good with that. An important teaching point, we said 2,000 Merkel's cases a year. The CDC might say 2,000 cases a year. We don't know because that's how many present to the system that the system identifies.
Well, how many get a biopsy and a pathologist looks at it?
Yeah,
Yes.
that's how many are. But there may be many, many more that we don't ever know about that never sought medical care or can't afford medical care.
Right, or the guy got of a heart attack and had a big old knot on his face.
Right.
Now that's going to be, up here in the mountains, that's going to be a lot.
You ready for my question?
Yeah, but you see people in the line, I would say line more at the dollar store or the Walmart, who have neglected skin things on their head and neck than you would see at the Neiman Marcus because they're going to go to the dermatologist. But that's common up here.
It's common. And they walk in your office and you can't take your eyes off of it.
See,
You're
how long
talking about
has
all
that
these
been?
other things you keep saying. Can we talk about this?
Go ahead, it's your turn. You want to
All
say
right.
something?
So, yeah, I do because this leads me, and you were talking, and you and I have been sitting on not maybe this couch, but a couch in the past.
They sell these so
And-
fast, it's a
right,
new
and-
couch
and-
every
and-
week.
And I remember you having, bandages right here and having.
My eyebrow went off after here.
Yeah. So I want to ask both of you very seriously, and not a joke. The first part is just a quick yes or no. Do you guys keep a hat with you at all times?
Yeah,
I have a hat at every door and in every car. But
Okay.
that doesn't mean I always have a hat with me.
No. Okay.
That doesn't
but
mean
here's
I
where
only wear
No,
it.
no. Here's where
Yeah.
I'm going with this. Okay, because you said something about I don't keep a hat with me at all times, but we've already hit 1 or 2 days, got right up in that 80 point, feeling good. We start running outside. We are just days away from that. Wow, it's time to go out,
Lakes opening up.
work in the yard, stuff like that. What happens? What changes? How serious should we stay covered for when we start getting out and working in the yard? And my question is pretty simple. Without getting into the ozone, is what happens when you ran around as a kid and you never got sunburned and you played all day.
I
No,
got
I got
sunburned 10 times a year.
Well, but not to
I
what I'm
did.
saying.
I got blistered. I got a
Okay,
big blister.
and
My mother would put a T-shirt soaked in Noxema on me.
well, I'm not saying you never, but you know what I'm saying, the difference. And then you go today and you're out in the sun for 15 minutes. You're like, wow, my skin changed. What changes? What changes?
First of all, your memory of your childhood is poor.
Well,
And
okay.
Or maybe you had a good mama.
Well,
I mean,
no,
she may
yeah,
have
but she
smacked him every time he went out with that.
Well, but she wasn't putting
Maybe, okay.
she wasn't putting
Just didn't seem like it.
50 sunscreen on him, because in his days they didn't have any sunscreen.
Okay, I was getting
Right.
ready. No, I was getting ready to
So,
say we
today-
didn't have SPF or whatever
right.
55. You know.
Yeah, it started out at 15 and now it's up to 100.
Right.
And by the way, you don't get much value above 30. But anyhow, so
30's a T-shirt, so
what? And your clothes.
that's what I'm
one-
saying. 30's a shirt.
Yeah, but one of your expert panel wears a brand of shirt exclusively that has sun protection built into the shirt, and it doesn't wash out.
Interesting.
Interesting. So now, if you're like me, I have a sunscreen right there next to my razor. So when I get through razoring, I do this. Now, I don't do a great job of it. You're supposed to wear that year-round. Now, that hat will help you if you're in the bright sun, but most of what you got to worry about is reflected off the road, and it's not direct sun. It is outdoors, and that sun is just as much in the winter as it is in the summer. It's just that the winter days are 10 hours long and not 16 hours long. Because in other words, that sun ain't going to be a lot worse in the summer than it is in the winter because
I have
the
a cool
time's
image
different.
about reflected light. On my trip, I was up in the
Sun.
ski slopes, and there were a whole bunch of kids coming off the slopes, and the kids all wear helmets now with goggles, which they didn't have on when I saw them, but they all had a sunburned beard.
And when
None
they
of them
take
had,
their
none of them were
goggles
growing
off, they
hair, but they all had reflected sun that was making their face brown hair and their eyes white. It was kind of a cute image.
They look like some kind of
Young and bearded kids.
well, yeah, they look like.
So how long can you be exposed to the sun before it's a
It's
danger
cumulative,
point?
cumulative damage.
It doesn't really. It makes a lot of difference what your altitude is, how much atmosphere is above you. If you're at 13,000 feet, you can
Skiing
get
on a
burned
glacier,
in
you're
10
gonna get a
minutes.
lot, yeah.
You can get burned in 10 minutes. So basically,
And you're blue-eyed and fair-skinned,
yeah,
and you're at more
need-
risk.
You need to keep stuff on your face.
Okay, got it. I
right.
do agree with that. What do we have for the news of the
Well,
week?
we got a lot of things.
Well, I mean-
First of all, there has been a 27% rise in COVID deaths in New York City in the last 2 weeks. You remember Omicron?
Did they get shot first?
No.
I'm just checking.
You remember Omicron?
No, I'm just wondering
Okay,
if they got shot in
we
the
had-
prime and then
They
tested
gave-
positive.
Oh, okay, that's a good.
I'm
question.
sorry.
We had Omicron,
Right.
and that was December 15th to January 30th, and 75% of people wandering around got it.
Right.
They did, but most of them weren't sick. Then you had Omicron .1.2.
B, yeah.
Now it's .1.2A.1.1. I mean, that's crazy. Not only that, but they're doing surveillance now. Where are they doing surveillance now? To tell you what virus is prevalent and what the number is. Now, I told you this way back about 18 months ago, that this was going to happen. And not only, but if you look at that Schmidt woman, all her thing today is about surveillance of toilet sewers.
Bathrooms, yeah.
Sewers. The sewers that in certain neighborhoods in Kansas City, they check what's in the sewer because you're excreting this in your stool for weeks after you're sick. And so now they can tell from how much is in the sewer how many people are infected and then what virus it is. And so this is now 75% of the virus in the United States isn't Omicron, it's Omicron 2.1.11A or whatever it is, and that's going up. So this ain't gone. Now, to the news of the day. Fauci clarifies we're out of the pandemic phase, and experts agree. I think what's happening is fatigue with the regulation business. And I remember when H1N1 flu and the Spanish flu and then the bird flu and then some other flu, people kept worried about it. This variant we got today is going to be a different variant in August. And
The fatigue is the exhaustion and the irritation and the righteous irritation of telling people what to do.
Right. Well,
They don't cotton to that.
Yeah, let me go to the next one. How many cases of COVID have been in Fannin County in the last week?
I don't know.
0. How many deaths in Fannin
Zero.
County? 0. So when they're saying that this is the prevalent virus and that the death rate went up, if the death rate went from 0, let's just say the death rate was 1, and the death rate the next week was 2, that's 100% increase
Right.
in the death rate. Well, if the death rate's almost nothing, and then it's nothing plus a little bit, 27%.
Now, if you have 3 cases
Well,
and then you get 4, that's a 27% rate.
Exactly. So that's what I'm trying to say is they're focusing on the percent. This 27% increase in death rate in New York State sounds terrible, although nobody was dying in New York State, or a tiny number were dying in New York State.
So here's the other irritation with me, Bill, is it's a virus. The world is full of viruses, bacteria, and fungi. The CDC, for whatever reason, guilt or shame, decided that they were going to monitor the virus and not the sickness, not the patients, not the disease. And so they're still running around swabbing and looking for the virus.
Well, now they can go to the sewer
And
and
then
look
go
for
in
the
the
virus
sewer
now.
and look for the virus. And they tell us how much virus is running around. That is different from disease.
Okay, now I'm going to stop you again. Where did this begin? Where did the
This
COVID
case-
begin?
COVID
COVID.
in a lab in China.
What's the first thing on the news list this week?
First human case of H3N8 bird flu found in China.
Found in where?
China.
Where was that
China.
found? In
China.
China?
Yeah.
Wait a
Probably
minute. one
down
more.
at that
You're in my
Wait a
friend.
minute. One more time.
Probably down there. The
Whoa,
bird
whoa,
was
whoa.
probably a bat.
First case. This is a big deal here.
Yeah.
I agree, but I'm
First
just saying.
case of H3N8 bird flu in a human found in China. Now you remember 2 weeks ago, they were killing tens of thousands of chickens in the United States, and the price of a dozen eggs went from 98 cents to $1.98 in a week because they were killing chickens. Now what happened before Thanksgiving? They told us you're going to have to take out a mortgage to get a Thanksgiving turkey because they're killing all the turkeys on the turkey farms because of bird flu. Now, was there bird flu in the turkeys and was there bird flu in the chickens? No, there was bird flu in the surveillance of the birds that they're in the population out there. 20,000 chickens didn't have the bird flu in that farm. 1 did. So they killed 20,000 chickens in one guy's farm because 1 had the bird flu. Now we got 1 people that's got the bird flu.
I think
in China.
I think it's very serious what you just said, and the only reason I said what I did is through COVID and other things, the fatigue. Some of it is the truth. Now I have a real question. No, I'm serious. I got a real question. Doesn't pertain to COVID. I don't want out without answering. I take a daily low-dose aspirin every day. This last week, the report that came out, I want clarification because God knows some of these experts came on TV, and some new study said the internal bleeding. So if you're 60, I think it was, or older, and you're taking a low-dose aspirin to prevent a heart attack, you may be having internal bleeding.
You are going to have internal bleeding.
Okay, so clear up what I'm talking about. I got it all I got it all over the map. You know where I'm going with this?
Well, the clarity is that it's not science. You look at large populations and you do thousands and thousands of observations, and then you scope it down and say, well, we have observed this is related to that, and therefore you should do these 2 things. They forget all about these other observations that they missed, like internal bleeding or other things going on. So it is the state of our profession.
We are refining our knowledge.
We're refining our knowledge, and we find out, but there was a consequence to that we didn't think about, and now we're seeing it.
Okay, now let's go back because what that tells you is that people are looking for a magic bullet. Mm-hmm. Ray has 5 patients a day who want him to be able to give him a shot or a pill to help him lose weight.
Right.
Okay, let's go back to the aspirin. if you have atherosclerosis, then that aspirin is going to diminish the chances that that artery is going to clot in your brain, your leg, or your heart. And the hazard benefit ratio is clearly on the side of taking the baby aspirin. If you are overweight, hypertensive, diabetic, without heart disease, and are taking that baby aspirin, thinking, well, I might not get heart disease with the baby aspirin, then is that hazard benefit ratio still there? I don't think we know the answer to that.
We don't, and the data's starting to say maybe
Right.
not.
But remember now, that baby aspirin also is going to diminish the chances that you're going to get colorectal polyps or that you're going to get colorectal cancer. They're focusing the benefit of that aspirin only on heart disease and the risk. But if there are other associated benefits to the aspirin, I'm not saying whether they are or they aren't, but it is absolutely clear that the patients who do take baby aspirin for prophylaxis have a lower incidence of colon polyps or colon cancer. But is that lower incidence high enough to make the hazard benefit ratio worth the GI bleed? I can't say that.
All right, so my question, every morning in my regiment is a low-dose aspirin. Yes or no?
I'm on it.
Okay.
I have atherosclerotic heart disease. I have known heart disease. So
Well,
I know the hazard benefit.
I have
Well,
Probably-
I can't take one because I'm taking Eliquis for my atrial
I
fib, and
get
that's
that.
even better.
Right.
So I'm
but
doing better.
I take a low dose every morning, and I don't care if people know it because you guys put everything out there where I'm concerned. No HIPAA here. But no, I've had my colonoscopy. Whether you know,
Take
you need,
it.
I have.
Take it.
I was told everything is fine. 5 year, come back in 5 years. I've had some scans as far as my heart. Got to, you know, and I do understand.
Calcium score 0?
Yeah, I do understand. All right. Anyhow,
Calcium score 0?
I don't know if it's 0.
I mean, below 100?
I don't know.
Yeah, he says he's not been scored.
You're supposed to know the number.
I'll check it out. I'll
You're
get back
supposed
to
to
you.
know your PSA.
My low dose aspirin, I was very concerned because they come on and they do these segments and try to scare the bejesus out of people.
That doesn't make any sense to me. That scaring part. I think to load people with the information that there may be a reason for you to discuss your low dose aspirin with your doctor.
Right.
Doesn't that make sense?
Yeah.
Why don't they say, look, I see patients with iron deficiency anemia every day, and some of that may be related to the low dose aspirin, but those people also have got angioplasties and carotids have been fixed, and I can just give them some iron and things all fixed. So what they should say is, we now know a little more about low dose aspirin. Don't just take it like you're taking a over-the-counter vitamin. Discuss it with your primary care doctor or your cardiologist or your vascular surgeon, whoever it was that recommended it. Because your cardiologist, your vascular surgeon, if you've had surgery or a heart attack, he's going to tell you to stay on it. And then your primary care doc may say, look, you're taking this like a vitamin and there's no indication that you need it. Why don't you stop? Talk to your doctor.
Or my moniker is have a doctor or a physician who treats you like a person, not like a herd.
You
Not
got
like a
anything-
chart.
You got anything today you wanted to?
I have
Where's your joke?
a personal share. It's not a joke, but it's funny.
Go for it.
As you know, I was on my deferred trip to Switzerland, and I was very good this time because, as a piece of background, most people know I did not come from highbrow means. Okay, fairly poor childhood.
Me too.
So anyway, I was really good this time. I only went in one watch store and spent any amount of time there. Okay.
How about your wife?
So I'm picking up
She went with me.
The watch store.
I'm
is-
wearing one of my nice watches.
Okay.
Your wife buys those watches, though,
She
right?
buys them, but anyway, she was with me. So I go in this store, and I don't know what it is about me, but the young lady, very sharp, black suit, white,
Attractive, too.
attractive lady, says, "Would you like to see a special watch?" And I'm like which watch? And she goes over, there's a little window in the wall, and she says, "This watch is not being made yet. It's on display. There's only going to be a few of them made in the world, but we have it this week, and it's going to the next store next week. Would you like to see it?" And I said, "Well, hell yeah." So anyway, they take me back to the little room where I think that these transactions occur because I've been there.
And they have to get an armored guard to stand.
No, there's a guard at the door. You don't get in the door
I
without a guard.
understand, but they got a guard for that watch, dude.
So anyway, I'm back there and I'm looking at this watch. It's a very, very nice looking watch. And I said, well, how much is this watch going to be? And as she was saying $800,000, I dropped it.
What? Are you serious?
I think it was the 800,000. I think the 1,000 is when my wrist went.
It was that high. Whoa,
was
whoa,
like,
whoa, whoa.
So the young lady gets up. I'm like, oh. And she's like, don't worry. And I'm like, I hope it's not broken because. So anyway, she picks it up. It's all fine. There's no scratches or anything like this. But anyway, I just want to let you know that your friend has dropped an $800,000 watch in his lifetime.
I know that guy. You know that you heard about the guy that dropped that 800,000. I could use that at parties.
And he didn't
You
buy
heard about
it.
the guy that dropped the 800,000. I know that guy.
So
yeah, I could do that. Okay.
Anyway, I'm sharing that because my children have not heard that story yet. I made Lee promise not to tell the kids about what their daddy did. Confessions.
Did the kids watch this program, though?
Yeah, well, they'll probably watch it now. They'll all find out together.
We are before a live TV audience. Let's have another laugh and a little clap over there. Come on.
At the reading, your father left you this watch.
He would have left you some money, but
Yeah, he left you,
got the
this watch. Okay,
Now
we
share
got to
it.
go. Anything else, sir?
No, sir. Donate blood. Let's go.
Load it. You got to get to work. Hey, we'll be back with the all-star political panel right after this.